This video is on the relations of the psoas. And, okay, first of all, everybody relax. It's just one of the muscles. It's not the only muscle. It's cool. It's a cool muscle. Like, don't get me wrong. Probably top 10? And maybe top 5. We'll go top 5. But anyways, we're going to talk about some of the relationships because one of our followers did ask to explain some of the relationships of the psoas. And he had some specific considerations that I want to point out. I'm going to try and keep it as general as I can to explain as many things as possible, but understand that it is the psoas and a few specific things. So he believed he had a short left psoas, weak glutes on left side, slouched, tried to correct it, which caused some upper back pain, and then there's some leg length and abdominal discomfort. And believe it or not, it's very reasonable that a muscle can cause some of this stuff just based on attachments, not all of it. Understand that any muscle, doesn't matter how important we believe it is, any muscle is part of the problem, not the entire cause, because muscles are controlled by nerves and they're influenced by a lot of different structures. So we can't say that one singular muscle is the problem. So let's assume we have a short left psoas, just so we're clear. This is the left side, this is the right side. And so we need to specify this left side has become shortened. It is contracting. And there's a couple of possibilities with that. And I did a video earlier on about how the calf muscle could become tight. And in this case, I want to make a more specific consideration simply because it's a chronic thing he mentioned. So I'm betting it's more of a fibrosis, a state in which we've been shortened for a long time. There probably was an initial contraction, but we have had some overlay, some thickening of the tissues to reinforce. Because if you hold a muscle in any kind of a contraction for long enough, it tends to thicken up. It tends to get a bit bigger, denser, and more rigid. And this is a defense mechanism as much as anything else. But it is an important one to consider because it's a lot less mobile than it should be. So I'm going to assume there was some contraction initially, ended up resulting in some more solid shortening, some shortening that can't be undone by reducing the contraction alone. So let's say we've got a left short psoas. I saw pictures. I'm not going to show those pictures. Didn't feel I needed to. I saw pictures, and I'm going to say why I believe this is the case. Now, second thing, we've got weak glutes on the left side. And just so everyone's clear, there's more than one glute. I believe he meant glute max on that left side. Again, this is left over here. This is right. That's more for me than it is for you because I forget constantly. I don't think I'm alone in that. Anyways, the glute max is approximately like that. Some of it feeds into the IT band. It's a very exciting muscle. Some of it, and lots of people actually, goes all the way into the coccyx. Very cool muscle. In any case, that particular muscle is oppositional to the psoas. If the psoas is here in the front, psoas attaches as high up as about, that was the wrong way of doing that, as high up as about L1, TVPs in the bodies, so it'd be more in the front, of course, and then it attaches all the way down into about here, through the front, of course, all the way down into here via the lesser trochanter. Let me just finish that off there. And so the psoas is considered a hip flexor, and that would mean if the glute max is an extensor, these two oppose each other. They do opposite things. So because of that, a psoas contraction, L1 to 3, tends to be the nerves that go to that psoas muscle. 1, 2, 3. And we have extensor capacity, and that's inferior gluteal. These are oppositional nerves. And so it means that one should reciprocally inhibit the other if they're contracting. That's our involuntary nature. We can understand you can contract your hip flexors and your hip extensors at the same time voluntarily. But generally, if there's heightened nerve tone, we just throw in a bunch of extra juice into this area, it will take away some of the nerve tone from this area if we're not aware and we're not really trying to counteract this effect. This is something we call reciprocal inhibition. So it's actually somewhat reasonable for him to say and claim he has a short left psoas. And I'm going to believe him at least in part because we also have weak glutes. If we've got a short contracting, like we've got more nerve tone going to the left psoas, we probably should see weak glutes on that same side. Further testing to really clarify it would be, do we also have, and he may not be aware of this at all, do we also have good, strong extensor capacity on the opposite side, the right, and weakened, diminished hip flexion on the right as well? Because that works in parallels. We call that crossed extensor. We're into the crossed extensor reflex now. But that would be something you'd want to follow up with in this case. So we're going to assume, again, we're going to assume he's correct. That's part of a justification. Now, interestingly, he mentioned that he also slouched to the right side. And that's important. Now, you may think that if we're slouching to the right side, and he's saying basically, I was bending a while ago. I was bending all the time to the right side. That's what felt comfortable for me to do. I was bending to that right side. You would think that the spine would be oriented like this, or perhaps like this, just a general curve to the right, and everything on this side was shortened here, whether that's QL, so as you would think that. But honestly, that's not usually the case. There's more compounding mechanics that happen in the spine. It's always just that much more complex than you think. So if you drop your arm to the right, and you can do this, you can see this in yourself if you want, have someone take a picture, it's fun to see. But what generally happens if you drop down and you start putting your arm on the armrest, you drop that arm lower, and so maybe the elbow's sitting there, and you drop the shoulders. What tends to happen is some of the curves will form this way. So you may bend in the upper thorax, upper and mid thorax in a confusing way, doesn't make sense. But the psoas ultimately can end up translated to the left. So it will go this way. It will tip, in fact, as if it were like so. I'm going to draw that out a little bit better. And so we'll get the side bending here localized more at the lower end of the thorax, and then it will curve back and around. So these are some of the more complex spinal mechanics, but the motion isn't happening where you think it normally would. You'd think it would just do this, kind of giant curve through here. Not the case. Not how it works in a lot of cases. So I'm going to just look at it from the front, just because it'll make a little more sense. So understand, a very important thing, is that the psoas is attached to the lumbar spine, and then it's attached to about L1, 2, 3, 4, 1, 2, oh, that's way too big, L1, 2, 3, 4, when I get the right breast side, 2, 3, 4. There is kind of a fascial connection tying in that TVP into the sacrum and innominate. It's sort of the psoas, but not technically. So we're going to go with 1, 2, 3, 4. And understand, when it contracts and pulls, this area of the lumbar spine doesn't really have much side bending. There's a little bit of 4 on 5. So it's not going to be able to bend when it gets pulled down. What it's going to do is going to operate like a chunk. It's going to operate like a bar. And so it tips here. Now it tips on L5, L5S1, and that can end up bending to the side effectively, bending and rotating at the same time. We're just going to focus on the bending for now. So that will drop along with it. But above it, it actually very much so operates like a bar, as if it was doing this. And so this is some of those very specific mechanics in the lumbar spine. You can get lumbar side bending in cadavers when they slice away all the muscles, but that's really not what we're going for. So anyways, what has happened, again, just to indicate, this is the right side, this is the left. The lumbar spine has tipped, it's dropped this way. This will all become more relevant, and then we've probably got it actually occurring at L5. So there's 5. Again, this is all very, very important. So even though he's technically bending to the right in his upper girdle, he's side bent to the left, meaning that left psoas, this left psoas is actually the shortened one, and it's been sustained there for a very long time because this slouch, as he explained to me, was there for quite a while. So we can justify more of the fact that it is a left psoas in addition to the weak glute because he was bending to the right. I know that's a really long way of doing that, but we've got to justify all this. We've got to make sense of it. Now, here's another thing. We've tried to straighten out, or he explained, he wanted to straighten out his posture. Good idea. He wanted to say, hey, I don't want to be bent all up anymore. I'm going to try and fix myself. And this is a good goal. Lots of people should, do that at one point or another. So let's say we get rid of all this. But here's the thing about that. It doesn't always go as smooth as you think it would. Oftentimes, when we've held things in a position for a long time, they've shortened and they will stay in that position. So whether it's the smaller ligaments and joint capsules in the area that get stuck, they get used to being shortened, and we know fascia does actually actively contract if you give it a long enough period of time to do so. It will contract and hold a state, and it can take weeks to months to years. And this is a very necessary thing. Your fascia needs to have a bit of a contraction ability, so it makes it easier to tighten up the body to hold a certain position. It should eventually relax, but if it's been there for too long, it starts to deform. And so it means that the muscles in this area, whichever ones you want to choose, if you want to choose the smaller ones like multifidus, rotatories, but we could also go with longissimus, and maybe even, we could throw in for sure the iliocostalis. I'm going to leave that one out, but let's just understand that we can shorten these muscles, and this psoas is shortened. So these are going to hold on. These are going to hold on to this area, and it's held in a side bending as well as a rotation. I don't want to talk too much about the rotation, but we can throw that into a spin as well. Understandable. That's usually how it works. If it's bent to the right, generally rotates to the left. So now it's stuck, and it's probably stuck bent forward as well if they're slouching, because that's what tends to happen. But now this area is stuck here. And because of that, when he starts to straighten out, when he says, okay, I would like to sit up straight, I would like a nice shoulder girdle position, a nice head position here, he's trying to straighten out some areas that are a bit more fixed. He noticed first pain in that shoulder area, some pain in the shoulder area. That doesn't actually last very long. That eventually goes away, gets used to posture, but we get a bunch of pain in the middle back and the mid to low back, so lower middle back. Basically, we're describing this fixation. So what has happened is a complex compounding of motions. So he wants to straighten out, which is great. That's a good goal. But we've lost some of the normal ability of the spine because the psoas is short on the one side. Because the psoas is short here, we've essentially stopped L5 from moving. We have eliminated some of that rotational ability. It's not going to go back and forth or side bend nearly as much. We can't do that anymore. So it's got to go kind of to the next highest area. Let's say we've fixed the psoas, as in we've stopped it from moving entirely. It's locked out, but we still need to rotate. We've straightened out through here. That means the motion wants to go to the next closely associated area. So if we can't move here, if this is locked out, we have to go up to the next spot. And the next spot for rotation tends to be in that 11 and 12 area. And even though it's probably stuck in a bit of a side bend, it's still going to attempt to force. And the psoas is probably the first one to happen. So it means that we want to keep moving, so we push harder and harder. We push harder and harder to form a rotation at that T11 and 12 area, maybe up as high as 10, maybe a little bit higher than that. And so what we end up doing is we tend to strain these muscles in here, these muscles that are pulling all this together, and it's going to be on both sides as well as above it, tend to get over torqued and overworked because they're doing the job. They're all doing the job of that L5 area. They're being asked to do more because, as usual, the user of the body has no awareness of the shortened muscle. Even if he has some awareness, doesn't mean they change what they do significantly. They keep pushing their body more and more. So it ends up straining some of these areas because they're just asking it to do more than it should, because we lack the ability at a lower point to do the normal job. This lack of awareness it's honestly a big problem for the human body. And you know, if you can get in there through exercise means or manual therapy means and start to reestablish normal motion, you can take care of a lot of these points of wear and tear that shouldn't normally exist. So the fact that the lumbar spine wasn't moving because of the fact of the psoas, because of the fact of the slouch and the compensation, that's probably why we were getting the pain through the shoulder and then into the low back. The shoulder would have been a reflection, more of like the lower trap muscle, maybe even the rhomboids at a higher point, but because it's settled on the middle back, that makes the most amount of sense. This is a compensation to a lower problem. In any case, as well, he mentioned he had one leg that feels longer than the other. And in a short period of time, it is quite impossible to change the length of a leg. You know, you've got two, usually, femurs and tibias and fibulas all the way down into the foot, all that complicated stuff that we're going to leave out for now. But understand, it's very possible to make it appear like a leg, or even make it feel like a leg is shorter or longer, just based on positioning. It's a fun experiment you can do, and it's usually done through internal and external rotation. If you want to just place your hands, so you would place your hands on top of your ilia, just that crest there, iliac crest, and you could stand in front of a mirror, that usually makes it better, and practice internally rotating your leg and see what height your hands are at, and then externally rotating your leg, going the opposite way with it. And you can see that your hands, if you give it just a little bit of time, you see that if the leg is rotated internally or externally, it can drive the hip up or down on the one side. So one side is as if it was longer, as if it was shorter. And this is because of the shape of the hip joint, the hip bones. So if we're looking at this part right here, if we're looking at it from the side, we've got an acetabulum, and into that goes the head of the femur. That's like the greater trochanter here, and there'd be a lesser trochanter, which you're familiar with right about there. Again, that's the attachment point of the psoas. So when the head of the hip, when we put it backwards, which would technically be internal rotation, we twisted it into internal rotation, it's pushing up differently against the acetabulum. When we go the other way, it's pushing up differently against the acetabulum. There we go. Like a pivot point, if you will. And this will drive it up or down. It tends to be as we internally rotate, get that right? It tends to be as we internally rotate, that leg goes as if it were shorter. So it's as if that hip will tend to drop down. As we externally rotate, that hip will be driven up partially. Now with the psoas, incidentally, it is a hip external rotator. It depends on the starting point, but just understand that because of its attachment, so if we look here, there you go, because of its attachment, because the lesser trochanter is a little bit behind in the femur to begin with, as we contract that psoas, not only will it pull it up into what we call hip flexion, so it'll pull it this way towards the body, but it will also pull it a little bit forward. And it doesn't have to be a lot. If you just put a little bit of external rotation in your femur, in your leg, you will notice that the hip can come up or down. And given enough time, especially if it just so happens that the constant contraction of the one side of the psoas, as one side goes up in pressure, the other side is inhibited, this will tend to favor internal rotation if we give enough time. So the external rotation we see on the left will be contrasted simply because we're moving around a lot and we're favoring certain types of motions. We'll tend to see that the one side with the shortened contracting psoas will tend to externally rotate, whereas the right side will favor internal rotation. And this is reinforced as you walk around, as you move and you do stuff. You don't even know this is happening most of the time, and it's building up gradually over time. So these are very real possibilities. He feels like one leg is longer, and at no point have the bones actually changed in length. It's very possible that simply the positioning of the legs makes the pelvis drive up on one side, which goes to further kind of reinforce what's going on. We're actually bringing these two closer together by driving the one side up, so further reinforcing that psoas shortness. Okay, last thing we want to talk about, abdominal discomfort. And first thing I have to say about that last statement is that if you have true abdominal discomfort, you do need to see a doctor. You got to rule out anything medically pathologic. You want to make sure it's not a disease. And once you've done that, you can further explore that relationship. And there's a few ways we could go about this, but some of the simple ways of understanding is if we have some irritation happening in this area right here, in this area of T10 down, and even as high as about T6, T7, you'll find that these nerves are actually what come around. So the nerves coming from here come around and go to the anterior abdominal wall. So this is getting to be a horrific mess, but I'm going to draw it right over top and hopefully it'll make sense. So the anterior abdominal wall, that's our rectus abdominis, for instance. That is these are our ab muscles, of course, our external obliques and internal obliques, which go that way. Transverse abdominis. Understand that T7 to about all the way down to a T12, T7 to T10, T12, those are the nerves that come around from that area of the spine and go and innervate, that's give nerves to, give sensation and motor power to the abdominal muscles. So that area of the spine here goes all the way around to the front. And so if we've got some irritation in the spine area, in the muscles and the ligaments, and especially if we're talking about ligaments and joint capsules, they have high sensitivity to pain. We might be getting some reflex pain. Again, see a doctor if you have some genuine concerns. But ruling that out, if you're getting some irritation into the spine, you can perceive it as coming from the abdominal area. Now another thing, and I just recently saw some studies on this, they have discovered, and they're using therapies now, that was the point of the article, but they're using therapies now to find out entrapment of these same nerves in the abdominal region. So as they pass through the fascia, it goes around the rectus abdominis, the rectus fascia, and fuses, really it brings together the obliques. Those nerves, as they go into that, as they basically spread through that tissue, go into it, they can become entrapped in this area. And this is very much a fascial restriction of nerves, just like anywhere else in the body. We know nerves can be impacted by the area. And, many times I would say it's not that it's a true entrapment in this case. It's not like it's being compressed. But if we're disturbing the fascia around the nerve by the fascia of the tissue with pressure and inflammation, you can have effects on the nerve. So, that was a real long way of saying, yes, the psoas does stuff in the human body, and if given enough time, it can be part of a greater series of problems. Because there is active contraction, because there's a chronic nature to this, it probably needs some work over duration of time, and hopefully this particular person who contacted me can find someone who can help them, because this is not an unreasonable thing to see a manual practitioner for, whether that's osteopathy, fascial stretch therapy, physiotherapy, and of course some kind of exercise therapy. These are all good ideas, but get it looked at clearly by a professional, of course. Anyways, this has been Simple Nine's Anatomy, and I'm Elge. Hopefully that made sense.